A very good morning to all of you. Welcome to another episode of Weekly Sunday webinar series hosted by the Sri Knowledge Academy. Today we have a topic related to psychiatry. Before moving on to the lecture, let's go to see some housekeeping rules. The webinar link will be open for you to join in from 9:15 to 9:45 a.m. No late attendees will be permitted to enter thereafter. You have to stay until the end of the lecture to collect the e-certificate and obtain the CPD points. Kindly keep your mics and videos turned off during the lecture. If you have any questions, you can type it in the chat box or you can ask at the end of the lecture. Let's move on to today's lecture. Today's topic is recognizing and treating depression in the community. And our guest lecturer is Dr. SUHASHINI Ratnatunga, consultant psychiatrist, National Hospital of Sri Lanka. She also worked as a senior lecturer in psychiatry, the Department of Psychiatry in the Colombo University Faculty of Medicine. Dear Madam, thank you for joining in with us today, and over to you to conduct your timely lecture. Thank you.
Thank you for that introduction. So welcome everybody, and sorry to have dragged you on a nice rainy Sunday where you could have slept in a bit more. But we'll probably focus on a very important topic where we don't give this much recognition in Sri Lanka. So we're going to talk about depression. Okay, it is going to be the commonest non-communicable disease in the world. And I think it's important that all of us are able to recognize it. And as MBBS doctors, we should be competent in treating it. And it's not a scary process to treat it. So we'll go through on how to recognize and how to start treating depression in the community. Okay, so first and foremost, in our culture, we are not very good at expressing our emotions. And even, as children, probably we were taught that, crying in front of other people or talking about your weaknesses is a weak personality trait. Okay, and this is actually part and parcel of a culture. As a result of that, we are not very forthcoming when it comes to negative or positive emotions, right? And we try to kind of hide behind negative emotions mainly. And as a result of this, detection of diseases like depression and anxiety are not common in our society. And therefore, there is a underprevalence of depression and anxiety in our society. And very rarely, even as a specialist, do I have patients coming to me telling me that, doctor, I have been feeling very low or I'm suicidal. And as a result of this, we see a lot of bad consequences. And usually we see depression when it has gone on to have complications. And the early recognition of depression or the early presentation in Sri Lanka are pretty low. Majority of patients in Sri Lanka present with depression with other symptoms. And I think it's very important that we are able to recognize these other symptoms, which will kind of make us kind of suspect depression in these communities, okay, in this population. So as community physicians, general practitioners, they are the people who will actually see a lot of these patients, right? Because very rarely do patients come to a psychiatrist with mental health issues because, again, of the stigma associated with psychiatric disorders. So in the general population, to the general practitioner, patients will present with somatic symptoms. Mage anga danawa. Mata tada hise kekkumak tiyenawa දැන් දවස් ගාණක් තිස්සේ සති ගාණක් තිස්සේ. Gastritis. Okay, so these are the common symptoms patients will present with, right? And again, if these presentations don't match with your physical examination, or these patients don't respond to your medical management, or they keep on coming back, rolling DOE patients, right? Then it might be a good idea to screen for depression. So somatic symptoms in the Asian culture is the commonest presentation of depression. Okay, even in the elderly, symptoms like constipation, increase in joint pains is also another common presentation. Right. A patient who presents with deliberate self-harm is intentional harm to oneself, has to be screened for depression. So this is the commonest cause of deliberate self-harm, depression. And if we don't recognize depression in a patient presenting with a suicide attempt, then it is a failing on our part. So you have to screen for depression, because this is generally a cry for help. Okay, if a patient, even though it is a low, it may sound like a low risk attempt, or your risk assessment tells you that this is a low risk attempt, Panadol piti pahak vila marane kohomada, right? But this is the patient's way of expressing his distress, his or her distress, right? So he or she is unable to present with or tell you that he's depressed. Even probably the patient themselves are unable to recognize that they're depressed. But this is their way of presenting. Okay, this is their way of calling for help. So if a patient presents with deliberate self-harm, you have to screen for depression, which we will talk about later. If a patient presents with a history of abuse, repeated abuse, especially domestic violence, patients with domestic clients presenting with domestic violence, the incidence, the prevalence of depression in that category is very high. Okay. So again, to the general practitioner, patients can come with bruising, problems, marital conflicts at home. And again, in this population, screen for depression. Fortunately, in the postpartum period, women are given a lot of recognition, a lot of prominence, because now they are, they have entered motherhood, and there is a lot of focus on the child and the baby, right? And when the mother is unable to perform maternal duties, so, fulfill maternal responsibilities like looking after the baby, breastfeeding, right? Usually family members will notice this. Babata kiri denna hitenne, babata kiri denna dan unanduwak naha, umanawak naha, right? So in the postpartum period, usually family members are more alert towards, changes in the mother. Okay. And they are able to kind of recognize, okay, look, she's not breastfeeding enough, or she's not interested in looking after the baby, and there is something wrong, right? And during this period, patients are brought to the, doctor. And again, remember, postpartum period is a very high risk period, probably the highest risk period for depression in a woman's lifetime. Okay. So we know that 1 in 7 women who have given birth to a child are at risk of going on to develop postpartum depression. Okay, so 1 in 7, that's a huge, that's a big number. Okay, so especially if a woman comes to you, postpartum one within the first year, always screen that person for depression. The other presentation is you might get patients coming with, substance use, substance misuse, patients coming with withdrawal symptoms. Okay, especially heroin withdrawal. Patients come commonly to the general practitioner, symptoms of heroin withdrawal. So don't just treat the substance misuse. Okay, majority, again, about 30 to 40% of patients with substance misuse, okay, have comorbid depression. Okay, so whilst treating the patient's substance misuse, also screen the patient for depression, because the likelihood that they are depressed is very high, right? And you need to treat the depression parallelly. Then another good indicator is we get a lot of referrals from physicians, surgeons, that this patient is not responding to the usual medical or surgical problem. So we commonly get patients from the endocrine clinic saying that this patient's blood sugar is not under control. hypertension is not under control from the medical clinic. This patient's wound is not healing. Okay, so worsening of medical conditions or medical conditions not responding to their usual medical surgical management. Okay, another common reason is depression. There is a neurobiological etiology for this. Why, depressed patients do not respond to usual medical or surgical management. But there are also other social contributory factors. Depressed patients are not compliant with their, usual diabetic or antihypertensive medication. Depressed patients will not go for their routine daily dressings or daily or, their dressing changes, right? So as a result of the depression, as a result of neurochemical changes in depression, there can be worsening of underlying medical issues, or as a result of the depression, because they are non-compliant with the medical or surgical management, the underlying medical or surgical problem can worsen. Okay. Right. So these are the common presentations of depression to you, non-specialists, or to the general practitioner or the community physicians. Okay. So, and remember, majority of patients present to you, not to a psychiatrist. Like I said earlier, because of the stigma associated, or because patients themselves are not aware, okay, that they probably have a mental health condition, or probably patients themselves don't want to believe, don't want to accept that they are depressed. Okay, they usually don't present to us, right? Or they present to us very late, sometimes too late. Okay, so it is, you have a huge role to play here, because they will present to you, right? But they will not present to you saying that I'm feeling low, I don't have the energy, I'm not interested in sex anymore, I'm not interested in studying anymore. They will present to you with one of these issues, one of these conditions. So therefore, keep your clinician, intuition, right? Be alert, and then screen for depression in this patient population. Right. Your clinical instinct, I would say, is probably the best indicator. Okay. Probably if you feel, okay, this man or woman might be depressed, I would say, that is the best indicator for you to screen for depression. Screening for depression is very easy. All you need to do is kind of have a clinical intuition. This man doesn't look good. Or you have been knowing this patient for a long time, and now, things have changed. The way he responds to you, the way he talks, right? That has changed. And therefore, screen for depression. Right. So I'm sure you probably remember some of these from your undergraduate training. So symptoms and signs of depression, it's easy to list out, but probably difficult to elicit. Right? Again, because they are not, it's like, eliciting physical signs, right? It gets better with practice. You have to be able to demonstrate the major criteria, the main criteria, which is low mood, lack of energy, or lack of interest, right? These are the golden signs that a person is probably depressed. Okay. Now, low mood is a bit tricky, right? If I say something nasty to you all at this moment, you will feel low, okay? If I say something horrible, you will feel low. And we expect you to feel low. A normal human being has, when we talk about reactivity of mood, normal reactivity of mood is where the human being reacts to, what happens outside or inside their environment. Internal or external environment. So if something negative happens in the external environment, like me saying something nasty, then we expect you to feel low. That is a healthy sign. Okay. But if you have been feeling low for no reason, okay, where you can't yourself say, I mean, there are so many things, doctor, for me to be happy about, but I don't feel happy. I feel down. Or if you have been feeling, I mean, somebody says something nasty to you, you're feeling unhappy, but you should be able to bounce back, okay, to a certain extent to your normal self. But if you're unable to do that and feeling low continues for 2-3 weeks, okay, without you being able to entertain any form of happiness, that is abnormal. Because what we believe is a normal human being, a healthy human being, will react to negative things in the environment, negative stimuli in the environment, but they are able, once that negative stimuli is taken away, they are able to kind of bounce back. But if you are depressed, you're unable to bounce back, right? And that low mood, that sense of despondency will continue for weeks. So that is abnormal. Patients with depression as a result of probably low mood, a lot of negative thoughts, have lack of energy. They will tell you, doctor, I mean, I haven't done anything the whole day, but I still feel so tired. I find myself dragging myself to bed. Okay, and I'm in bed. And after being in bed for 3 hours also, I feel sad. I feel that I'm not rested. I feel that all the energy in me has been drained out. When depression worsens, it goes to a level where they don't even have the energy to brush their teeth. They don't have the energy to have a wash, look after them. They don't have the energy to eat, get up and eat something. That is how bad it becomes. Okay, so we have patients as a result of lack of energy, low energy, especially elderly patients coming to us, patients who have not eaten or drunk anything for days, whose life is actually at danger. Physical health is at danger, right? Because they have not been eating and drinking. Then there is this other feature, which we call anhedonia in psychiatry. Sorry, there's a chat message. Oh, sorry. Okay. So this feature, this symptom is very common in adolescents. Okay, teenagers, young adults, where they have lost interest. So if you talk to a teenager, if you ask them what their interests are, they will tell you, I like to play cricket, I like to watch TV, I like to, chat with my friends, right? And this joy of, interacting with people, engaging in hobbies you enjoy is taken away, right? So they have lost interest, okay? Lost interest in, the things that used to interest them. So you need to find out what this person was interested in earlier. From person to person, it will differ. So ask this person, what did you used to do? What did you enjoy? What gave you happiness earlier? Then they will tell you, playing with my grandkids, watching TV, reading books. But now none of that interests me. I don't even feel like talking to anyone. I just, stay in bed the whole day. Okay, so these are the cardinal features of depression, right? And if patients say yes to one of these, then the chances of depression are very high. With these features, we also get other features. We sometimes call these minor criteria or supportive criteria to diagnose depression, right? So these are ideas of self-harm, low self-confidence, low self-esteem. Patients with depression don't believe that they are able to achieve anything. That things that they were good at, they are not good anymore. They are not good at it anymore. And they feel that, life is, useless. And as a result, they start entertaining ideas of self-harm. Okay. Depressive cognitions are cognitions that, are usually seen, not pathognomonic, but usually are present in depressed patients. And these are hopelessness, helplessness, worthlessness. Okay. You feel that, I'm helpless. I'm unable to do this. I'm unable to complete this task. I don't have the capacity to carry on. Worthlessness means, I am worthless. Okay, where I don't have, the I don't have what it takes to, go on in life, right? And hopelessness is a very dangerous symptom in depression. Usually patients with hopelessness, if it is undetected and the depression is not treated, go on to entertaining ideas of suicide, okay, where they don't see the future anymore. They are unable to kind of entertain alternative explanations. So they have lost all hope. And the only thing they see forward is ending their life. Okay, so these are called depressive thoughts, depressive cognitions, which you need to again ask your patients. Then patients with depression will have biological symptoms of depression. Biological symptoms are sleep, appetite, and libido. And patients with depression will tell you, I can't sleep, or I go to sleep, but after about 2 to 3 hours, I wake up, right? And then I can't go back to sleep. So there is a hallmark sign called early morning awakening. When they go to bed, they will sleep for a few hours, but then, around 2, 3 in the morning, they wake up, but then they can't go back to sleep. They don't have the appetite to eat, right? And this is again dangerous in especially elderly patients. And also sometimes, patients come to the VOG saying that they don't have libido, okay? And good VOG is actually screened for depression in these patients and usually find that they are depressed. And therefore, just treatment of depression per se can basically improve their libido, okay? So low libido is a good, another good sign that a person is probably having depression. Then medical students come to us, or university students come to us saying that nothing, I am unable to retain anything. Okay, I go for lectures, all the information just go over my head, or I have been reading the same page over and over again, but I don't seem to be able to retain it. Okay, it's as if I have been spending time with my books for the past 5 hours or whatever, but still I can't remember anything. So this is another feature of, depression. So cognitive symptoms of depression, okay, cognitive symptoms, poor attention and concentration, which eventually lead to poor memory. Right. So remember when you got your patient, when patients present with these symptoms, somatic symptoms, deliberate self-harm, etc., you need to ask these questions, right? And if patients, if they say yes to a majority of these questions, then the chances that these patients are depressed are very, very high. Okay, it's safer to assume that a patient is depressed than not. Okay, right. Okay, so when we try to understand why do some people who seem to have so many problems, okay, right, they have lots of psychosocial problems, but they seem to be fine, they don't seem to get depressed. And also, why do some people who seem to have everything, they have a lot of money, they have a lot of friends, they have a lot of qualifications, they seem to have everything in life, but then how many stories have you heard where a very successful businessman, mother or father of 2 children, everything, has committed suicide? Okay, right. So depression is a prototypical example of how our genes and environment interact. Okay, very similar to your diabetes, hypertension, or certain cancers. Okay, so depression is another example of how our genes and environment interact to produce depression. Okay, for the manifestation of depression. So there is no 1 or 2 genes that will bring about depression. Okay, it is a multifactorial process. But we do know that in families where there is a family history of depression, the chances that the offspring, first-degree relatives, will get depression are high. It is higher than a family without depression. So there you go. There is a genetic contribution. We still have not been not been able to isolate genes, but we know that problems in your serotonin transporter, norepinephrine transporter, dopamine transporters, problems in these receptors have genetic defects in these receptors, transporter systems have been implicated to produce depression. Then we know certain psychological traits, certain personalities are also predisposed to develop depression. For example, patients with neurotic personality traits, neuroticism, highly excitable, worrying type of personalities are also more predisposed. So your psychological makeup, okay? And the other side of the coin is if you are very resilient, if you have, now some people are trying to isolate resilient genes. Resilience means where, you're not affected by what happens in the environment. You're able to withstand that stressor, okay? So neuroticism versus resilience is also, so resilience is a protective mechanism, whereas neuroticism is a risk factor to go on to develop depression. And also social factors, things that happen in our society, in our culture, in the external environment. The best example is childhood abuse or childhood trauma. Okay, we know that children who have unfortunately had childhood trauma are more at risk of going on to develop depression. And also ongoing social factors, domestic violence, ongoing relationship difficulties, financial stressors, work-related stressors, marital stressors, okay? All this can also contribute to depression. So can you see it is an interaction? It's a bad combination of all of this. Okay, a bad combination of genes, social factors, psychological factors that will come together to go on to develop depression. So that is probably why we see, some patients who have lots of clients who have lots of financial problems, marital problems, work-related stressors. They don't seem to get depressed, probably because they don't have the genes that will express depression, or probably they have a different psychological makeup, right? And this is probably why we see, patients with all, socially they seem fine, but they present to us with depression. So it is basically a multifactorial etiological model that gives rise to depression. It's important to understand this model because it is the same model that we use in the management of depression as well, which we will talk about later, okay? Right, so what is the point of this lecture? Why are we, spending, a valuable 1 hour of a Sunday when we could have done much nicer things than listen to this lecture? So the importance of why we have to recognize and treat depression is we know depression is the commonest cause for suicide all over the world. 800,000 people die of suicide all over the world per year. Okay, so that is almost close to 1 million. And, in certain countries where suicide is considered illegal or, not in keeping with certain religious faiths, suicide is not even reported. So that is a gross underestimation of the rates of suicide, okay? So unrecognized or untreated depression is the commonest cause of suicide all over the world. Okay, so it is important that we recognize and treat depression because that will translate to, management of suicide and avoidance of unnecessary suicides. Okay, apart from the risk of suicide, there are also other risks associated with depression, which I'm sure you and I can relate to. If, let's say, a student in their O-levels and A-levels become depressed, right, there is a risk of academic underperformance, academic deterioration, right? And as a result of this, students are unable to do their O-levels, A-levels, any important exam. And this is going to have drastic consequences on, a person's academic life. Especially in Sri Lanka, where, O-levels are held just once a year. There is no repeat exam. A-levels are once a year, no repeat exam, right? This is 1 year of a student's life, okay? So academic deterioration, risk of academic deterioration. Unrecognized depression, especially in the elderly, okay, can lead to premature death as a result of patients not eating and drinking, patients not being compliant with their diabetic, hypertensive, or antihypertensives, right? So there is deterioration of physical health, okay, which is a risk factor for worsening morbidity and mortality, right? Then also, when we talk about functioning, we look at lots of aspects, not just, activities of daily living, but functioning, interpersonal functioning, recreation, okay, functioning in the workplace. And as a result of a person being depressed, right, you can have, all these areas of functioning being affected. Just try to imagine, right, when you're depressed, you're unable to, perform well at your workplace. When you're depressed because of irritability and, lack of interest, that can affect your marital life. Okay, you become more quarrelsome with your spouse, you don't have a libido, there is no sex life, right? So all this is affected, right? And you are probably someone who enjoyed gardening, playing tennis, whatever, etc., and you're not going to be engaging in any of those. So there is a problem with functioning as a result of, an ongoing depression. And also worsening of physical illnesses, right? We know that, long-term medical illnesses, right? Diabetes, hypertension, chronic wounds, cancers, right? There is a worsening of this. There is a direct relationship of, chronic pain syndromes, right? Direct relationship between these illnesses and depression. And there is a deterioration of physical health or a deterioration of these physical illnesses as a result of comorbid depression. And treatment of a comorbid depression will directly translate to improvement in the comorbid physical illness. Okay. And there are certain conditions, like now we have recognized that untreated depression is a risk factor for myocardial infarction, especially in females, right? So if you are able to treat depression, you're in a way reducing one risk factor for myocardial infarction. Then secondary psychiatric phenomena. Secondary psychiatric phenomena is, we know, again, untreated depression at any age, even during adolescence, right? Even depression during adolescence is a risk factor for dementia. Okay, so untreated depression is a risk factor for dementia. Untreated depression is a risk factor for substance misuse, right? If we follow up certain patients, a cohort of certain patients, right? If we don't treat the depression, they go on to start experimenting substances, right? Psychoactive substances, or their substance taking behavior increases as a result of untreated depression. Okay, so secondary psychiatric phenomena as a result of unrecognizing and not treating depression. So that is why we are talking about depression today. Okay, so now I'm sure you're competent in recognizing depression, right? It's not difficult, right? And once you recognize depression, how am I going to approach this patient? How do I treat it? Okay, depression all over the world, okay, depression is treated by your, first contact primary doctor. And that is how it should be, okay? And majority of, primary care specialists are very good at treating depression. One reason why they are good at it is also because they have developed over a number of years, they have developed a relationship with their patients, right? And patients trust them, and the patients are likely to follow what their primary care doctor has prescribed for them. Okay, because again, and also a primary care doctor is better at probably diagnosing and recognizing depression in their patient, because they have known this patient for a long time. They have known the patient for years, and now they see a change in the patient. And sometimes the patients are more forthcoming with their doctor, whom they have known for many years, right? So as a result of this, your recognizing depression might have a higher yield, right? And your management might even be better because you have developed a good therapeutic relationship with your patients. However, there are instances where you may want to refer and tell the patient and refer the patient to more specialized services, to a psychiatrist. So look out for red flag signs, right, where a patient is depressed. With these red flag signs are better managed, or probably safer managed with a specialist's opinion. Okay, where a psychiatrist might be able to do something more different or look at the patient in a different angle, and this might be important for you to know. Okay, so what are the red flag signs? Okay, so when you diagnose depression, one part of diagnosing and manage, or one part of the management, is a risk assessment. A risk assessment where you will screen for certain risks in the patient. And in depression, the most important part of the management is to screen for a risk of suicide. So a suicidal risk assessment is imperative in a patient with depression. And if you feel that the risk of suicide is high, then that patient is better managed by a specialist. Okay, so in the indications of a high suicide risk are if your patient tells you that they feel suicidal, okay, or they feel that it's no point living, it's better off if I end my life. If this patient has a past history of suicide, deliberate self-harm, a past history of attempting suicide, right, a family history of suicide, okay, if there have been any final acts, okay, where, patient has been, transferring his property to the next of kin, things like that, okay, or whether the patient has been researching methods to end their life, okay, all this will indicate a high risk of suicide. If that is the case, then these patients are better off managed by a specialist. Patients with resistant depression. Resistant depression are where you have been treating depression with antidepressants, but the patient does not seem to respond. So what we usually say is give a trial of antidepressants for about 4 to 6 weeks, right, with the SSRI. But if the patient is not responding, then you can obviously try another SSRI. We'll talk about that, another antidepressant. Right? So if a patient has been given an adequate dose and an adequate trial is 4 to 6 weeks of antidepressants, and the patient does not seem to show any improvement, those patients are classified as resistant depression or difficult to treat depression, DTD. Okay, then those patients are better managed by a specialist. Again, severe depression presenting with psychotic symptoms, poor oral intake, these patients again are better managed by a specialist because they might probably require electroconvulsive therapy. That is one thing. The other thing is, if a patient has psychotic symptoms, they are very unpredictable. Okay, and these are the patients who are likely to go on to commit, suicide, right? So a patient presenting with psychotic symptoms, delusions or hallucinations with a depressive episode are very unpredictable patients, right? They can even harm other people, right? Then as a result, they are better managed in a specialized environment. Patients who are presenting with depression, but with a past history of probably hypomania or mania. Okay, because bipolar depression is probably one of the most difficult conditions to treat even as a specialist, even to a specialist, they are very challenging, right? They're very hard to treat. They require majority of patients require a lot of drug trials, okay? So again, rather than, experimenting with drugs, these patients are better managed because there are now new advances in managing bipolar depression, right? So these patients with a history, presenting to you with depression, but with a history of mania or hypomania, are better managed in a specialized setting. Postpartum depression and psychosis, again, are better managed by psychiatrists, mainly because management is challenging. And we also need to look at the welfare of the baby. Now there are mother-baby units in DMH. There is a mother-baby unit. In NIMH, there is a mother-baby unit, right? So mother-baby. Sometimes patients might have to be admitted, right, under a specialist. So in these cases, because of the risk of infanticide, because of the high risk of suicide, these patients are again better managed in a specialized service. Dual diagnosis is where patients have two psychiatric diagnoses. Commonest is a substance disorder. So patients with depression and a comorbid substance misuse issue will also, probably because their medical management is going to be complicated, okay, and they might need psychological support as well, not because the management is challenging, but because the management requires a more multidisciplinary approach. These patients probably are better managed in a multidisciplinary setting, okay, where there is a MDT, right? Almost all other patients with depression can be effectively managed in the primary care, okay? Right. So how do you decide? There are lots of options when you go on to manage depression. How do you decide which treatment for which patient, right? It depends on, mainly for me, if you look at different, consultants might say different things. All that is correct. This is my choice, okay? I usually look at the severity of the episode, okay? And depending on the severity, whether it is mild, moderate, or severe depression, I will tailor-make my management plan. Remember, management of depression is individualized. What works for patient A will not work for patient B. Okay, which is why sometimes treating diabetes, hypertension is very easy, right? You can follow protocols, right? But human beings are different. In the sense, human beings, every human being has different experiences in life, isn't it? Right? So that is what makes us unique, and that is what makes us different from the other person. So my set of experience are different to the 216 other participants' experiences. Each one of you are different. Almost all of you all will have similar blood pressure readings, but your experiences in life, and as a result, how you look at adversity, how you respond to certain problems in life are going to be different. Okay, therefore, treatment of depression is individualized because of that biopsychosocial model we spoke about, right? Okay, so severity. So to me, mild, moderate, severe depression will define the way I treat my depression. That is one thing. The other thing is, if this is a patient who has had a previous episode of depression, the past experiences of this patient, of the treatment, will give me an indication as to what will work now. The golden rule is, what has worked in the past will work now, most often, especially when it comes to drugs. If the patient tells you, doctor, I took sertraline last time, it had no effect on me, then don't waste your time giving sertraline again. If the patient has been given a good dose in the past, okay? Not a subtherapeutic dose. I went up to 150, no response, then I won't waste my time with sertraline. I will choose something else, okay? And also take the patient's preference into consideration. If the patient tells you, with fluoxetine last time, I had sexual problems, but you think fluoxetine is the best drug, no, it is the best evidence base, you prescribe fluoxetine, the patient is not going to take it, right? And your alliance with therapeutic alliance, your therapeutic relationship with the patient will just break, right? So you need to listen to your patient as well. Even though the evidence base says, drug A is superior to drug B, but the patient says, drug A, I had so many side effects with drug A, then don't go for drug A. You need to go to drug B. Right. Psychological management plays a huge role. That is, when we talk about psychological management, we talk about psychotherapy, or sometimes some people call it talking therapy. When it comes to mild to moderate depression, yes, okay, that is the evidence-based, current evidence, especially for mild depression. Psychological management is number one, okay, and there is usually no place for medication, okay, and there is a gamut of psychotherapies now available. Easiest which you can deliver in the primary care is what we call supportive psychotherapy or solution-focused psychotherapy or problem-solving therapy. And you can read the NICE guidelines. There are lots of guidelines, but NICE has a nice account, right? Or the Royal College of Psychiatrists as to how to deliver, very basic psychotherapy. And usually for mild to moderate depression, it works very well. Medication is advocated for patients with moderate to severe depression. Again, remember, in severe depression, right, don't waste your time with psychological therapies, right? Severe depression requires medication. Of course, both can go parallelly, right? You can, while giving psychotherapy, while giving medication, you can give psychotherapy. Sometimes the depression is so severe, patients won't be able to even engage in psychotherapy, right? Then in that case, you start medication first, and once the patient starts responding, you can insert your psychotherapy, right? But moderate to severe depression, medication is first line, right? Lots of suicides could have been prevented if patients were medicated earlier, right? Because of the stigma associated with medication, medication is the last option for a lot of families, right? But by that time, patients have either attempted deliberate self-harm, marriages have been broken, schooling has been stopped, okay? Right? Medication will do more good than any harm when it comes to severe depression. And that is something you need to convince your patients of. First line is your SSRIs. Almost all are available in Sri Lanka, freely available in the government sector. At the moment, we have sertraline and fluoxetine. In the private sector, we have escitalopram and citalopram. Fluoxamine sometimes, but generally they are not our first line. Paroxetine, again, available in the private sector, but usually the drugs we like with less side effects are these drugs, okay? Your second line is if you feel that an SSRI is not adequate, right, then you can also go for venlafaxine, which is an SNRI, and now duloxetine is also available in the market. In the government sector, we have both, right? SNRI is considered slightly more powerful than your SSRIs because it has 2.5 actions when it comes to your monoamides. It will increase your serotonin as well as your norepinephrine, and at some places even some dopamine also. Whereas SSRIs will only increase one monoamide. Okay, and also mirtazapine, which is not an SNRI, it's a NASA compound, which is also very effective in managing more severe forms of depression. Resistant depression, I have not discussed today, right? But resistant depression is where we treat the depression with antidepressants, but augment. Augment means to further enhance the activity of antidepressants with other medication, like atypical antipsychotics, lithium, okay, drugs like that. Okay, I think this is probably the most important slide when it comes to managing depression. So one pitfall I see in my practice is that in the primary care, patients have not been compliant with their medication, okay, or have stopped their medication too soon once they feel a good, therapeutic effect, good symptom control, or sometimes patients have been under-medicated. And also because patients have not been informed well. Remember, all drugs have side effects. That is one thing you need to tell your patients, right? Anything will have, adverse effects, right? But fortunately, majority of the adverse effects associated with antidepressants are troublesome but not dangerous, and with no long-term consequences. Very, very, very rarely are there dangerous side effects like serotonin syndrome. But, in my practice, I have probably seen about 3 or 4 patients with serotonin syndrome. Again, those patients were on high doses, right? But there are troublesome side effects, definitely. The GI side effects, yawning, some somnolence, dizziness. But majority of these side effects actually go away in about 4 to 5 days' time. So if you inform the side effects, especially the GI side effects, which are the common side effects to your patients, right, they'll be happy to, once they get the side effects, they will know what to watch out for, and they will be reassured that this is not something, unusual, and that these side effects, if I power through it, they'll be okay. They will go away in about 5 days' time. So you need to inform the side effects when you prescribe the drug. So the BNF will have about 50 side effects, okay? But, the main side effects are the GI side effects when it comes to antidepressants. Again, the problem is these drugs are not like paracetamol, where, you take it today, you're better tomorrow, right? Unfortunately, you feel the side effects first, but the benefits later. Again, you need to tell this to your patient. Usually it takes about 10 days to 2 weeks for the patient to expect a change in their mood, a change in their energy levels, right? So the change is expected only after about 10 days to 2 weeks. Okay, and this has to be informed to the patient. Otherwise, they're just going to give up because they're only seeing the downside of the drug. Okay, so they're just going to stop the drug in about 5 to 6 days. You need to medicate the patient adequately. Majority of the patients who come to me are on a subtherapeutic dose, and obviously the therapeutic effect is not going to be, an adequate effect, right? So don't worry. So you just follow the BNF. It has guidelines as to how to increase and how to achieve a therapeutic dose. For example, with your sertraline, you will start off with 25, but you need to go to about 50 to 75 to get that, therapeutic effect. So you need to increase the dose adequately. Patients don't like to take antidepressants because they feel that they are drugs of addiction. Okay, no study so far has proved that antidepressants cause addiction and that they cause dependence. You have to tell this to the patient. If you ask 10 patients, 7 of them will tell you, I thought that antidepressants or all psychiatric medication are addictive. You need to dispel this myth. Okay. Okay, the last slide. I just put this slide so that you will be asked this question. Okay, usually when I sometimes recommend ECT, the patient goes and asks their primary doctor, "Doctor, what do you think? I trust you more than the psychiatrist. What do you think?" Okay. ECT is basically prescribed only by psychiatrists only if they feel that it is absolutely required. Psychiatrists like to manage patients with medication and they don't like to give ECT. Okay, they are not trigger friendly when it comes to ECT, right? But if a psychiatrist decides that a patient requires ECT, it is most likely that the patient definitely requires ECT. Okay. ECT, so patients will ask, I'm going to be electrocuted. What do you think about this? Right. So it is, you have to tell the patient it is not the current that goes in our walls, okay, that run in our wires at home. It is a minor electrical impulse. right? And it is better to start this early than late, right? I sometimes feel, patients have been suffering for a long time and then finally, ECT is considered. That is not the case, right? There are definite guidelines for ECT. If you want, you can read the Royal College guidelines for ECT. And if a patient meets that criteria, okay, or that requirement for ECT, we have to go ahead with it, because the rate of deterioration of that patient is going to be very fast and sometimes going to be irreversible. Okay, right. So ECTs, we give ECT every other day in our ward, and we have not had casualties with ECT. It's a very safe procedure. ECT actually per se is not dangerous. It is, the risk comes with the general anesthesia, right? So, any surgery that requires general anesthesia, it is the same, type of, or a milder form of general anesthesia that is given. Okay. So whatever risk that is with ECT is the risk of general anesthesia. Okay. Some people worry that ECT causes long-term, I won't be able to remember my mother, father, wife. Okay. Long-term memory disturbances are very, very rare. Okay. And it is, you won't forget who you are or anything. About less than 1% of patients will have, less than 1%, okay, will have some memory disturbance, some autobiographical memory disturbance related to those couple of hours or probably that day before and after ECT, but usually a couple of hours before an ECT and after. That is why we say, don't write a will a couple of hours before you're going to get ECT, or don't do any financial transactions a couple of hours before the ECT. That you might forget. Okay. But generally, you're not going to forget how to drive a car. So your semantic memory is preserved. Okay. How you played the piano, nothing will happen to that. It is mainly your autobiographical memory closer to just before and after getting ECT. ECT is given for quick recovery, but that doesn't mean you can stop your antidepressants. ECT doesn't work, or patients will relapse if they get only ECT. ECT works only whilst patients are on antidepressants. So some patients ask me, okay, so can I stop all my antidepressants when I get ECT? No, you can't. Patient has to be on a good therapeutic dose of antidepressants, and on top of that, they are getting ECT. Okay. Right. Okay. So that is the end of our lecture, exactly 10:30. Right. So let's ask, yeah, go ahead.
Thank you very much, madam, for your informative lecture. And it's a very practical one as well. Interestingly, we have some questions in the chat box.
You're going to read, or you want me to read?
Either way is fine, madam.
Okay, I'll read it. How to motivate depressed patients to seek help that are in denial of existing? Yeah, very good question. So this is a problem, we also face. One thing is probably kind of, getting a key person in the family to kind of, tell the patient, let's just, a majority of patients are worried that they will be medicated, okay, or that they will get ECT. What you need to do is probably just, let's go and talk to a doctor and see, whether your symptoms are actually due to a mental illness or probably due to a physical illness. So sometimes, hypothyroidism or some autoimmune conditions, right? These get present like depression. So sometimes we might even want to exclude an underlying organic condition that might present like depression. So one thing to tell these patients is, let's go and talk to a doctor and see whether it is probably not a mental, whether there is any other thing, that can make you feel like this or make you behave like this, and whether we can get help for that condition. Other option is for you to say, look, I had the same symptoms, or get somebody to say who had depression to talk to the patient to say, I had, something very similar. And then I went and, got help, and now I'm better. Okay. So kind of, associating symptoms. That is one thing we can do. But I understand it's very difficult. Okay. That is why, especially, abroad in Western cultures, It is fashionable to go and meet your shrink. It is fashionable to go and meet the psychiatrist, okay? But in Sri Lanka, that is not the case. So it's very difficult for patients to present to us. Despite having depressive genes, can someone stay out of getting depressed, or are they anyway going to develop? No. So that is what we talk about, the gene environment interaction. Okay, that's why. So some patients with depression don't go on to with a family history of depression don't go on to develop depression. And yes, there are things you can do to protect yourself from depression. One thing is substance. I mean, what we have seen is, substance use, alcohol, smoking, staying away from substances is a protective factor. 0, okay? Not even social, 0. Physical exercise is considered a protective factor. Social interactions, having good, positive social relationships. It's not the number of Facebook friends you have, okay? It's about having 1 or 2, 3 good people, relatives, friends whom you can open up to, who make you feel good, who improve your self-esteem. Social relationships have been found to be helpful. Then, if you yourself have good relaxation techniques, some people say, I find meditation to be helpful. I find dancing to be helpful. If you have cultivated some good habits where during times of stress, you can use it, okay, then that is another protective factor, right? Rather than some people say, when I get upset, I just go and have a drink. So those are maladaptive coping strategies. But adaptive coping strategies, if you have, mastered them so that at times of difficulty, you can employ them, then those are considered protective factors. Should adjustment disorder with depressive symptoms be treated with medication? If so, what is the best treatment and how long? Right. So adjustment disorder and depression are 2 different conditions. Okay. The criteria to diagnose adjustment are different to the criteria to diagnose depression. But yes, if, let's say you have had a recent grief, okay, and as a result of that, you go on to develop depression. And if the depression is moderate to severe, then yes, you have to treat it with medication. But also, if this depressive episode was triggered by grief, okay, then some grief therapy. So there is a psychological therapy. A grief therapy might be helpful. Or if this depressive episode was triggered by an interpersonal conflict, right, then yes, an interpersonal psychotherapy might be useful. How do you differentiate depression with psychotic features with schizophrenia? Right. So depression with psychotic features, the depressive symptoms will come first. The patient will have low mood, lack of energy, insomnia, all that. And after a few days or a week, the psychotic symptoms will come on first. In schizophrenia, usually, either the depressive symptoms and psychotic symptoms come together, or the psychotic symptoms become, very prominent and they come on first, and you might even have sometimes first-rank symptoms. Okay, so the psychosis is more prominent in schizophrenia, whereas in depression, the mood symptoms are more prominent. Okay. Oops. Sorry. We stop sharing, no? We don't need, and we can stop sharing. No, yeah. In a patient coming with panic attacks, what are the initial steps of management? So panic attacks is very different to, it's a different condition. In a panic attack, you need to first confirm that it is a panic attack, right? And after that, you need to kind of manage the initial panic attack. Usually panic attacks last for less than 3 or 4 minutes. Okay, so if there is hyperventilation, then breathing into a brown bag and all that. But then you need to find out whether the patient has an underlying anxiety disorder and whether the panic attack was as a result of that. And then you need to treat the underlying anxiety disorder. What are the important steps in examination? Can you please explain the MMSE briefly? Okay, that is beyond the scope of this lecture. MMSE is a cognitive assessment that is done to screen for dementia. Okay, it has nothing to do with depression. So MMSE is freely available on the internet, and maybe we can probably organize another lecture on dementia so that we can talk about MMSE. Okay. How do you up-titrate antidepressants and how long should they be treated? Right. So the first depressive episode is treated for 6 to 9 months. Second, if it is a recurrent depressive disorder, the second depressive episode is treated for 9 months to about an year. I would generally go for treatment for about a year. Anything beyond that, sometimes it might even be lifelong, sometimes it might be 2 years. It depends on, the severity of the depression, whether there are subthreshold depressive symptoms, any risks involved. Okay, the longer, it's better for long-term treatment than short-term treatment. In peripheral OPD setting, if we identify a depressed patient and start an SSRI, and if the patient has an improvement also, should we still have, no. Should we still refer to a psychiatrist? No. And how long a patient? No. So if a patient is, you're more than qualified to manage depression, okay? But you will refer if the red flag signs are there while the patient is on the red flag signs I described. If there are red flag signs, you refer. Otherwise, manage the patient. Patient will be happy about you managing than coming to a psychiatrist. Coming to a psychiatrist in Sri Lanka is very stigmatizing. Okay, patients don't like to come. So it is better if you can, confidently manage a patient in the community. So keep the patient and monitor the patient, monitor the mental state. But of course, if there are red flag signs, don't take risks, then you refer the patient. How does memory impairment, how the memory impairment can happen before ECT? So in depression, before ECT means, right, so memory impairment can happen in depression. Okay, some patients say me ECT දුන්නට පස්සේ තමයි මට අමතක වෙන්නේ නැහැ. අමතක වෙන්න ECT වලට කලිනුත් අමතක වීම තියෙනවා. So remember we said poor attention and concentration, that will lead to poor memory. Okay, so if a patient has memory impairment before ECT, that is as a result of the illness, the disease. When should we refer to the psychiatrist? After those red flag signs. What is the management plan for a pregnant woman who had a history of moderate to severe depression to protect from postpartum depression? Do we refer them to a psychiatrist? Yes, ideally, I would say postpartum mother who has had a history of depression should be referred to a psychiatrist. Okay, our midwives do a wonderful job in the community. Okay, they have a screening tool called the Edinburgh Postnatal Depression Scale, which is given to all mothers in the postpartum. And from that scale, from that screening tool, they pick up mothers and they refer them to us. So they are doing a fantastic job. But yeah, if you know of any mother with a past history of depression and then who has now recently delivered, it might be better off if they make contact with a psychiatrist just so that their mental state can be monitored. Once we notice a child with depressive symptoms, how can we approach to him directly? Yeah, they can. I mean, there are child and adolescent psychiatrists in Sri Lanka, and these children can be referred to the child and adolescent psychiatrist. Is the setting of a cancer and oncology ward, most of the newly diagnosed patients are in low mood or depressed. Is there a way to help psychotherapy or medication? Yeah, so if they meet criteria for a moderate to severe depression, make sure, they will benefit from medication, definitely, right? But remember, I mean, even you and I will feel very low and upset, okay, when we are diagnosed with cancer. So there is a psychological reaction to cancer as well. But on top of this, if a patient becomes depressed, then there is a place for medication. But psychotherapy has to go hand in hand, especially, in cancer patients, because they are now dealing with, for them, impending doom, right? And very harsh types of treatment. So psychotherapy plays a huge role, yes. What are the community supportive services that we can refer patients? So there are helplines, right? The Angoda has a helpline, Sumitreo. There are a lot of institutions in the community that are willing to talk to patients, and offer treatment. Okay, no? Any objective tool to diagnose depression? Any object where there is the Beck's depression scale. There is the California depression scale. Then there is a scale which was made by Sri Lankan psychiatrists, by the Peradeniya psychiatrists, called the Peradeniya depression scale. Then there is the Hamilton depression scale. You can use scales, but your clinical impression trumps any scale. Okay? If an MBBS doctor comes and tells me, doctor, I think this patient is depressed. However, the Beck's depression scale tells that the patient is not depressed because the score is very low. I will trust you over that scale. Okay, your clinical judgment is gold standard when it comes to diagnosing depression. Okay, I will just throw the Beck depression scale and believe you. Okay, it is your clinical judgment that matters. These are all supportive tools. Okay, the scales. Okay, done.
Right. Thank you very much, madam, for that very informative lecture, very practical one, as well as answering all the questions that was put in the chat box. So I would like to thank again Dr. SUHASHINI RATNATUNGA, consultant psychiatrist and senior lecturer in Faculty of Medicine, University of Colombo, for her valuable time in joining in with us today on a Sunday morning to deliver her lecture. Thank you, madam, again. And I thank all of you for joining in with us today on a Sunday morning. And I hope you will join in the next episode of Sri Knowledge Academy weekly Sunday webinar series as well on the next Sunday morning. Thank you very much. Hope you all have a good day.
Good day. All the best.